Hey, ladies and gentlemen, welcome to this PowerPoint presentation on chest X-ray interpretation. I am Matthew Vincent, a board-certified family nurse practitioner, the lead nurse practitioner at Lake Charles Memorial Emergency Department. We are a Level 3 trauma center. I just wanted to give credit to Dr. Todd Thoma from LSU Health Sciences Center in Shreveport, who the majority of these slides belong to. He generally gives this lecture either live or web-based, but was unable to, so here I am. So you can read the outline here. Some of this will be a review. Some of this you may have obtained in other classes, either in this program or other programs. Dr. Aaron may have gone over some of this with you as well, but we're just going to review very basic X-ray principles, look at normal chest X-rays, the anatomy, what you are responsible for when interpreting one, different views, and then we're going to get into some pathology and abnormal findings, and then finish up with line placement, ET tube, and central line placement. So in case you didn't know, an X-ray is a photo taken with the machine which passes electromagnetic radiation through your body and captures that image on a plate. So this is a bit of a simple but busy slide. Essentially, this is an X-ray is emitted from the source. It travels through space and time. It strikes an object. The denser the object, the more energy is absorbed. The less dense the object, the less energy is absorbed. It strikes the plate, and you get an image. So the denser the object, the more energy it will absorb, and the less that will strike the plate. So the denser it is, the whiter it will appear on an X-ray image. The less dense, the less energy is absorbed, or the less of the beam is absorbed, and the more of the beam is striking the plate, which will come back blacker. So more dense objects such as bone, dense soft tissues will be whiter. Air and less dense things will come back blacker on a plate. This is just another slide explaining the exact same thing. Less dense things are at the top of the tube, more dense things are towards the bottom. And then the top right is a metal marker which absorbs nearly all the radiation. So the more it absorbs, the less beam strikes it, the whiter it becomes. So as we get into chest X-ray assessment, I want you guys to be aware of some things. Number one, regardless of the purpose of viewing a chest X-ray, whether you're doing a screening exam prior to procedure, whether you were checking placement of catheters and tubes, when you look at it and you view an X-ray, you are interpreting it, and you are responsible for everything that is on that image. You're responsible for knowing what everything is on that image. And you are responsible for assessing and relaying that information on. So, in today's world, we think, well, I looked at it, but this is going to be read by a radiologist, and he or she will catch it, and that's the safety net. It may be true, however, what if this patient has a ninth left posterior rib fracture that you miss, the radiologist misses, they have a bad outcome, 1 week later they have a tension pneumothorax, and they die from it, or just have a bad outcome. Then you perform malpractice because you didn't interpret and relay that information correctly. You didn't correctly read that X-ray. So know that you're responsible for everything on that image. And I'm not trying to scare you. I just want you to know that you're not just looking at the lung spaces, that we're looking at the humeral heads, the proximal humerus, the clavicles, the scapula, the spine, the ribs, the diaphragm, the upper part of the abdomen for free air, the liver, the heart, the pulmonary arteries, the lung tissue, the cervical spine, the soft tissues. All of that is on this chest X-ray, and we're responsible for it. So look at it. This class is just an introduction. It's not meant to overwhelm you. You certainly won't be highly proficient at reading X-rays if you weren't going into this class. This is an introduction to X-ray interpretation, to chest X-ray interpretation. But as you go on in your studies and as you go on in your career, you will become more and more proficient at this. And so realize that when you're done and you're graduated and you're practicing and you're looking at an X-ray, you are responsible for everything on that image. This slide is just basic lung, lobar, and airway anatomy. This should be a review, but I put it in here so that we can look back on it if we need. Note in this one that the right main stem bronchus is more vertically angled than the left main stem. We'll talk a little bit more about that later as far as placement and pathology, but you can see that here. This slide is more chest anatomy on a chest x-ray. This one includes some of the landmarks. The next few slides are going to list all the landmarks that we need to know. This one's good. As far as for Et2 placement and catheter tip placement, locating the superior vena cava and the right atrium. The right atrium is significantly lower down than a lot of people would think when viewing a chest x-ray. So just make note of that. You can also see the trachea and the left and right main stem bronchus. They're a little hazy in this one, but again, this is just for study and review. Look at this slide, put it in your brain. We're going to talk a lot more in depth about these things as we move forward. So this is more internal chest anatomy on a chest x-ray. This one's showing the airways, the trachea, the right main stem bronchus, the left main stem bronchus. Again, you can see on here how the right main stem bronchus is more vertically angled. You can see the carina, it is not marked, but we will get into that later. On the lateral, you can see the trachea and the left main stem bronchus. Here's another slide with normal internal chest anatomy on a chest x-ray. This one has quite a bit of markings and landmarks identified, especially the superior vena cava, the right atrium. Those are going to be important as far as placement. One thing I want to point out is the pulmonary arteries where it says PA with the 3 arrows. Look at those. You'll see this on any chest x-ray. This is a normal finding. A lot of times when you're new interpreting chest x-rays, we'll see this and maybe want to think it's an infiltrate or something, but it's just the pulmonary arteries. You'll also see these little round, circular, whited out dots bunched up with the pulmonary arteries, and all those are cross sections of the arteries that are running towards and away from you, for lack of better terms. So you'll see these little circles, they look like nodes or something, and they're simply just cross section of the arteries that are running horizontally to and from you. So more anatomy just to get to know. This is more anatomy on a lateral view. Again, I'll remind you every slide, these are here so that we can get used to looking at x-rays, identifying landmarks and anatomical structures, and what it is we are looking for in a normal x-ray. So just study these. It'll, to find pathology, maybe find placement, to find abnormal things and understand what they are and be able to articulate that. We may have to look at 1,000 normal x-rays before we begin to find one abnormal and identify it. But this is just for your review here. Here's another slide with normal markings and anatomical structures. One thing to note on this one, if you look in the middle, it's got the dorsal spine marked, and I want you to start thinking about this, and we'll talk about this a little further in the upcoming slides, but you're looking at the dorsal spine. You're looking at the back of the spine through the patient towards the front, because this is a PA view of the chest, which is the gold standard. This is a posterior anterior view. The person will be facing the plate. The beam will be going into their back onto the plate. So think of that when you're viewing, because we tend to look at this and think we're looking at the front of a patient towards the back. It really does help in your mind interpret things when you start thinking about that. It's an evolution, but just put that in your brain, and we'll talk about it more as we move forward. So this wants you to identify the costophrenic angles. This should be reviewed, but do you know where they are? On a plain film or on radiologic terms, this is called a costophrenic angle. In an anatomical terms, this is a costophrenic sulcus. But do you know where the costophrenic angles are? So this is radiologic lung zones, not lung anatomy, not lobes. These are zones. So these are used for descriptive terms whenever describing an x-ray. These upper, middle, and lower, either right or left lung zones. We all know the left lung only has 2 lobes, so we're not talking about lobar anatomy. But when you're speaking about an x-ray, interpreting an x-ray, dictating an x-ray, yes, you can use anatomical structures to identify where things are located, but you can also say the upper lung zone, the middle lung, and the lower. A little bit more normal anatomy. Nothing much to say on this slide. Just study it and put it in your brain. More anatomy. Keep reading, keep studying. I know a lot of this seems redundant or repetitive, but it's just easier to break these down on separate slides than to try to jumble all this into one slide and make it real busy. So just really study these as we move forward and move on. Talk a little bit about gender in x-rays and chest x-rays, or as we say south of I-10, gender. So the main thing regarding gender and interpreting chest x-rays is the breast tissue. Yes, I'm not being funny, but some men will have denser breasts and breast tissue as well, whether it's gynecomastia or they just have large breasts, but for the most part, we're speaking about women. As well as breast implants and augmentation. So the main significance is breast shadows, the breast shadows that superimpose the lung tissue when viewing a film. So in females, often the breast tissue obscures the lung tissue whenever viewing a PA or AP of the chest. A lot of times we'll look at a chest and we'll look at the lower lungs and say, oh, they're hazy looking. They look like maybe there's an infiltrate there. Even though we're aware that the breast tissue is there, that we're looking through that, we still think something's there, but it's hard to differentiate because of that. This is really true in women with lactating breasts, denser breast tissue, fibrocystic breast disease, women with implants. Of course, the implants will obscure it. And so in these cases, just get a lateral view of the chest where you can look at the lung tissue and see, is that an infiltrate? Is there something there? Or is it just dense breast tissue? So this is just a model of the lung showing the airways and the lobes. These next several slides, we're going to discuss each lobe of the lung. Don't worry, I won't bore you to death. We're just going to basically speak where they're located anatomically and go through the slides briefly. So the description of the right upper lobe is fairly straightforward. It is located in the right lung. It is located superior to the other lobes, and it takes up about 2/5 of the lung space. The right middle lobe, again in the right lung, it is located inferior. It is actually anterior to the lower lobe, so take note of that, when you're looking at it on the left image, which is the PA, and then the right image, which is the lateral view, how anterior it is to the lower lobe. So when interpreting x-rays, sometimes it's hard to differentiate. Is this middle lobe versus lower lobe pneumonia, infiltrate, mass, etc.? If you look at the image on the right, the lateral view prior to COVID, I never really realized how much that image looks like a man or a woman wearing a mask, and the middle lobe is the mask. So the right lower lobe, it's a large lobe if you look at it on the left and the right. It takes up nearly half of the lung space. It is located mostly inferior and posterior to the other lobes, with a small portion of the superior aspect located inferiorly. There is a diagonal line that transects the lung, creating the superior border of the right lower lobe. I know some of this seems boring and redundant, but what I really want you to take out of this is look at these images as we're going through this lung anatomy and lobe anatomy. We tend to forget that the lung isn't just transected by horizontal lines and the lobes are cubes. They're really different and not what we would think. And so when interpreting x-rays, keep in mind where those lobes are located. As we know, the left lung has two lobes, the left upper lobe and the left lower lobe. This is the left upper lobe. Again, if you look at it, a little bit of the medial aspect of the lung on the anterior portion is actually the lower lobe. You can see where the heart shadow is. The lower lobe is visible through that little unblued out area. But anyway, it's a large lobe, transects the lung in a diagonal line that separates the two lobes. And here's the left lower lobe. Again, keep in mind, we may want to call something left upper lobe pneumonia, but look how far up the lower lobe goes into the lung. Again, these are for review purposes. These are to sort of burn these images into our mind so that we know what we're looking at when we interpret these films. All right, so erect posterior and anterior view of the chest. This is the gold standard in chest x-rays. This is generally where the person leaves the bed, is wheeled down to x-ray, stands in front of an x-ray box or plate. Sometimes we'll put their arms around it, hug it, and an image is shot. But this again may be reviewed. Dr. Aaron may have covered this, but an erect posterior anterior view with the lungs inspired. The patient is located 72 inches from the x-ray source or the x-ray tube. Again, they generally will have them, there's lots of techniques. Sometimes they'll have them hug the back of the plate or box, and this is to abduct the scapula away from the midline so that you have a better view of the internal chest. So erect posterior anterior, gold standard. So it's a PA versus an AP. So this is a posterior anterior on the left like we just discussed, and the other one is a supine AP. Main difference is the distance from the source. Again, in an erect PA, they're 72 inches away from the source. In an AP, the patient is 40 inches away. Seldom will you see a patient wheeled down to x-ray. For an AP, they're generally going to have a portable done in the bed. Just another image of the erect posterior anterior. And this is another way to get the scapula abducted from the body. Here's this guy against the plate doing the funky chicken. I'm not sure what you call that, but this is pulling his scapula away from the midline. The image on the right is the image that you should obtain. They'll have to shoot this x-ray again because they clipped the costophrenic angles and didn't get all the lung tissue in there. Or maybe I didn't get it all in on the slide, but just a view of this. This is a lateral view. Note that they have the patient holding on to a bar or trapeze or an IV pole or some hurricane debris coming out the ceiling, depending on where your hospital is located. But this patient has their arms away from the body so that you can get an appropriate view of the chest. A lot of times, attention isn't paid to lateral views. We don't see a lot of lateral views done, at least in the emergency setting. Because of time and throughput, we generally are doing portable chest, but very useful in differentiating and interpreting abnormal findings in a chest. So it's a supine anterior posterior chest x-ray. Again, these are generally going to be portable. Seldom are you going to bring a patient all the way down to x-ray, have them lay on their back and do that. Unless you work in a real trauma center that has good overhead x-ray equipment. Otherwise, it's going to be a portable chest, anterior, posterior view. And these views lead a lot. Number one, it's not the gold standard. It is not the best for viewing a chest. Number two, depending on position, placement, distance from the source, certain things are going to be obscured or magnified anatomically, making it difficult to interpret. But, it happens. We use them. It's just not the gold standard. Okay, so a lot of talking on this slide. Read it, turn the audio off, read over these diagrams, try to understand this, but then turn it on and listen to me speak. So this is an AP versus PA projection. So the top is an anterior posterior projection. And so in an AP, this is trying to show you how the heart will appear larger in an AP than a PA because the heart is farther away from the detector. Not the source. The heart is further away from the detector or the plate or the box. Okay? And so the beam is more divergent. It strikes the heart. It continues to go outward and sort of magnifies the heart when it strikes the plate. In a PA, posterior anterior view, the heart is nearer the detector and you're going to get more an appropriate size similarity of the heart. The heart is going to appear more normal in size because, again, that beam is divergent. It is going out. It strikes the heart, but the heart is closer to the plate, so it has less time to widen, less space to widen, for lack of better terms. So study that. You may see that in an X-ray interpretation of the of a portable chest or a PA of the chest or an AP of the chest, and the radiologist reads it and he says heart appears large in size, may be exaggerated because of portable technique or because of AP positioning. So that sort of explains why that happens. So another slide comparison on PA versus an AP film. The main take home from this slide is that a posterior anterior erect view is the best way. It is going to cause the gas to travel up and fluid to travel down because of gravity, so it makes pneumothoraxes more evident and more able to be seen. Pleural effusions, hemothorax, all that is going to travel down. Whereas if you're in a AP film with a patient supine, that fluid may pull up posteriorly along the lung, and is a little difficult to see. So PA versus AP film, how to differentiate the two when viewing them without knowing how it was done. Look at this one. Is this a PA or an AP? It looks like a PA because it looks like a normal chest x-ray looks, and any one you normally look at, but how do you really differentiate? And it's the position of the heart. So look at the heart as opposed to the midline structures of the mediastinum or the spine. The heart is, in this case, posterior or behind the spine. It is not superimposed upon it. The spine and midline structure are superimposed upon the heart. So this is a PA view, looking from the posterior going to the anterior, and for lack of better terms, with the spine in the back and the heart in the front. This is a PA view. So what about this view? Is it PA or AP? You look at the heart. It is superimposed upon the spine and the other structures, so the heart is nearest us more anteriorly, and so it is an anterior-posterior film. This isn't the best study, but hopefully you can see that the heart overshadows the spine, not vice versa. Flip back between the two, and again, pay attention to the heart. It's really the best way to tell. X-ray alignment. How do you tell if an X-ray is a patient is properly aligned, which is centered and not rotated? And the answer is you find the thoracic spinous processes and their relation to the medioclavicular head. So find those spinous processes on the X-ray. The distance from each of those to the right or left clavicular head should be the same. You can see the bottom image, that patient is not centered, they are rotated. The left clavicle head is nearer the spinous process than the right. And that's basically it. That is how you determine rotation. So is this film centered? I'll give you a hint. The easiest way is to look at the spinous processes of the thoracic vertebrae and their distance from the medioclavicular heads. An easier way is to click up one slide because it is the exact same image as we just used on a patient with an X-ray that was not centered. This one is not centered. Not centered, told you. So here's another one. Is this film centered? Again, find the spinous processes of the thoracic vertebrae and their relation and distance to the medioclavicular heads. Just practice this a bunch and use it. You may say this is a obscured X-ray, or it's hazy, or it's hard to find. It's not really the best image. And the answer is none of them are. They're all difficult to find, those clavicular heads. So just get used to looking at them, finding them to determine centeredness of X-rays. So I'm sort of breaking this down into sections, but I want you to get to a point where you can put all of this together. And we're not quite there yet, but when viewing an image, we should be able to tell, is it a PA versus an AP? Is this image centered? Are all of the pieces of a chest X-ray located in this film that are supposed to be in there, i.e. the cosophrenic angles, all the lung tissue, the airways, the top to the bottom of the lungs? That is really what we're evaluating. So we should be able to tell if this is centered, if it's an AP or if it's a PA, and then begin to identify some abnormals. So rib fractures, a few things to talk about. Numbering ribs, counting ribs. That seems to be a difficult thing for a lot of people. How do you count ribs? How do you determine anterior ribs versus posterior ribs? So let's look at this chest x-ray. First off, is it centered? Can you tell? It looks a little rotated. That right clavicular head looks a little closer to the spinous processes. Number two, is it a PA or an AP? It's a PA. You can tell the heart is behind the spine. You can tell the spine is superimposed upon the heart. So we're looking posteriorly into anteriorly. How do you determine the ribs being posterior versus anterior? Again, you can look at this and try to determine which ones are superimposed on which. So you see the ribs starting out of the spine. Just, for instance, look just below the clavicle on the left. That rib goes out horizontally, and then it curves around towards the front, curves around and goes down. So posterior ribs more longitudinal, anterior ribs slightly vertically down. Here's another example of that where the posterior rib, fourth rib on the right side, goes out horizontally, and as it goes anteriorly, you see where it curves and then curves downward. So here's rib counting. Again, posterior on the left, 1 through 10, and then anterior on the right, 1 through 6. You can see why it's a little easier to count anterior ribs if you look at the right side, beginning with the first rib that wraps around and goes downward. That's 1 through 6. On the left side is posterior. Start way up top at the cervical ribs and count downward. So either method, I would say get used to both and learn both. Rib counting. Look at the bottom of this slide where it says posterior ribs on the right, anterior ribs on the left. They're speaking anatomically. When you look at this image, the anatomical right, which is the left side of your screen, versus the anatomical left, which is the right side of your screen. Sorry, that's a little confusing. But posterior ribs are going to be numbered 1 through 9 or 10 that you should be able to see. And the anterior ribs are 1 through 6. You should be able to see 6. So I know this is slightly confusing, but use the number of ribs to help differentiate. So posterior ribs on the left side of your screen, anterior ribs on the right side. And just look at the difference how the posterior ribs, you start way up top on the left of the cervical ribs. They sort of go out horizontally and they terminate at the lateral chest wall, not literally, but the image does. And then the anterior ribs on the right side, those are the ribs that curve around and down, numbered 1 through 6. So study this, get used to it. So here's a rib fracture where the arrow is pointing. Again, look at this chest x-ray in general. Is it PA versus AP? Is it aligned? Again, it is PA. The spine superimposes the heart. It looks a little rotated on those clavicular head on the left side of the screen is a little close. And then now that you are sort of being able to see what posterior anterior view looks like, and you can look at these ribs, you can visualize this, that these posterior ribs are superimposed on the anterior ribs. So they look more apparent because they're closer to us than the anterior ribs. And so this is a posterior rib fracture. If you go up and count, 1, 2, 3, 4, 5, 6, 6 rib. A 6 rib fracture. Here's more rib fractures. This is an x-ray of a child. You can tell it's a child by overall appearance, by the size, and then if you look up the humeral head, it is not developed. But this arrow points to a rib fracture. So it says 1, 2, 3, 4, 5th posterior rib. Look below it, the 6th is also fractured, and look below that, the 7th is also fractured. So I would say this is a posterior left fifth rib fracture with mild displacement, sixth with moderate displacement, and seventh non-displaced, no evidence of pneumothorax. So cardiothoracic ratio in determining heart size. This is A plus B over C. A is the portion of the heart left of the midline. B is the portion of the heart to the right of the midline. And then C is the diameter of the internal chest cavity or the lung space. And so A plus B divided by C, the number you should get should be somewhere between 0.42 and 0.5 is a normal cardiothoracic ratio. Anything beyond that is considered cardiomegaly. Hey guys, listen, don't get caught up, and I hope I didn't confuse you on one of the earlier slides. When I'm talking left from right, I need to clarify that. Sometimes I'm talking about the left side of the screen versus the anatomical left portion of the chest in the image. So, for instance, cardiothoracic ratio, I'm talking about the left side of the image when you're looking at it contains the right atrium. The right side of the image when we're looking at it contains the left ventricles and the other aspect. But look, don't get caught up in all that. Cardiothoracic ratio, simple. The width of the heart, A plus B, divided by the width of the internal chest cavity at the level of the diaphragm, where it's the widest. So the width of the heart divided by the width of the chest, the number you should get is 0.42 to 0.5. Those are normal cardiothoracic ratios. And an old school method some of the guys used to do would be to measure the heart with your finger on the image with your finger and thumb, measure how wide it is, scoot that over into the left lung, and it should take up that width. The width of the heart that you measured should be the same width as one of the lungs, right? So if it's 0.5 is the number you're coming out, that means your heart should be half as wide as your chest cavity. So think of it in those terms. A little more heart anatomy on a chest x-ray. I'll put this in here as we move into cardiomegaly and then some of the other placement images that we're going to be coming up on. But look at the superior vena cava, look at the right atrium. Picture taking those lines out. You know, when we're looking at tip placement in the superior vena cava, that's a ways up there compared to the right atrium is a pretty good ways down there. So again, these are images just to become comfortable with and burn into our brains. So this is a real patient, it's a real image. In order to protect HIPAA and patient confidentiality and the patient's privacy, I will not use any identifying markers or patient information, but I just wanted to relate this image to real life. So this is an image of a 312-year-old Tibetan woman who made her annual pilgrimage down from the Himalayas to Starbucks for a venti caramel brulee hot with an extra shot, no whipped cream, a medium passion tea lemonade, and a raspberry scone. And while she's there, she recalls that the Dalai Lama told her to get the cough checked out while she was in town. So she went to the local Tibetan urgent care where they shot this x-ray and they said, "We really don't know why you have a cough, but you have an enormous heart. You have cardiomegaly." And this cardiomegaly could be due to congestive heart failure. It could be due to long-standing untreated hypertension, or it could be just that this woman takes care of all the village children and has the biggest heart in Tibet. But this is a classic, horrendous example of cardiomegaly. This person has a very large heart. Pleural effusion on chest x-ray. This looks to be a posterior anterior erect and lateral view. You can tell it's erect because the fluid volume has descended into the right lung space. This is a definite walled off effusion. You can see the lateral view where it does the same. This is very easy. This is a very large pleural effusion. This is a layered pleural effusion, sometimes difficult to differentiate from other things. However, a decubitus view, lateral decubitus view, shows the pooling of the fluid in the pleural space with large effusions that you can see. It's really not indicative, really offers no benefit to do a decubitus view, but it does help whenever you are having trouble determining, or you see haziness, you lay them on their side and you see it pool. Anything greater than 1 centimeter indicates about 200 mils of fluid in the pleural space, and is indicative or necessitates a thoracentesis. Pericardial effusion. This is a quite large one, quite obvious one. They don't always look like this, but this is a pericardial effusion, fluid in the pericardial space. You can look at the image on the right. Again, look at the image on the right. Is it centered? Is it a PA? Can you identify all the structures that you need to identify? You look at the size of the heart, cardiothoracic ratio versus the one on the left. Just by guessing, you can tell that the image on the right could definitely fit inside the right lung, and the image on the left could not. But you can tell it's pericardial effusion because of the haziness surrounding the heart, because of the size, because of the globular appearance. Not always is that there, but this heart has a globular appearance, loss of the normal heart contour. This is a large pericardial effusion. Another pericardial effusion, again, globular appearance, irregular shape, loss of the normal heart contour, big heart, or big appearing heart, which is the fluid around it. Look up, you can see the airways, the trachea, the right and left main stem bronchus. We haven't got into this yet, but it looks like a widened mediastinum, non-rotated study. Looks like he's got some increased vascular congestion, evidence of developing pulmonary edema, possibly congestive heart failure. But the main thing in this image is the pericardial effusion. This is what it looks like. Study it and burn that image in. So we'll get into some pneumonias and lung masses and other things in these next few slides. As you recall earlier, from our anatomy of the right middle lobe and where it's located, you can see this as the front of the mask if you were to look at a lateral view. But this is right middle lobe pneumonia. Lobar pneumonias, sometimes they're not always this definitive. You don't always see the boundary markings where nearly an entire lobe is marked off, or in this case about half of it. Sometimes you just see some streaky opacities or infiltrates, but this is definitely right middle lobe pneumonia. Right upper lobe pneumonia, as you recall, the right upper lobe takes up nearly half of the right lung, at least the anterior aspect. You can see the lower border of the right upper lobe. Again, not always are pneumonias and infiltrates this definitive. This is a great example of one. So right lower lobe pneumonia, again, think back or look back on the previous slides when we studied lobar anatomy, where the right lower lobe is. It really helps you differentiate right lower from right middle lobe. If you look at this image, you see this a female patient, likely a female patient with some breast tissue. Look in the left lung, how it's a little hazy in front of the breast tissue as compared to the upper lung zones that are more clear and black appearing. So that sort of helps you. But look at the lateral view. Okay, so this patient has some breast tissue. Immediately behind it is the heart, but you can look at the lung spaces and tell that this patient definitely has some pneumonia there as well on the lateral view. Again, is this aligned? Looks like it is a PA view. Right lower lobe pneumonia. Look up at the airways, the trachea, the right and left main stem bronchus. Recall earlier when I told you that the right main stem bronchus is a little more vertically oriented than the left, so that makes it easier for aspiration pneumonia, aspirate, foreign bodies, things of that nature, just because of the way gravity falls, and these objects will go down the right main stem bronchus more easily than the left. So you typically will see some aspiration pneumonia, more so on the right, but not only. You can see it in the left lobe as well. Foreign objects, small coins inhaled, safety pins, things like that generally are going to go towards the right side. Covet pneumonia. I only put one slide up here. I know we've all had enough. No, I really did just want to touch on this. Covet pneumonia, when you look at this, and this is not a very profound example, but this is what a typical Covet pneumonia looks like. You can look and see in the interstitial space, and I mean in the interstitial tissues, you can see the ground glass opacities, which when you look at these lung fields, it looks like there's pieces of ground up glass in there. This is typical of viral pneumonia. Covet pneumonia normally is more widespread and affects both lungs and all lung fields, where some viral pneumonias or pneumonitis isn't quite as widespread, but Covet pneumonia, widespread, ground glass opacities, no definite walled off infiltrates or lobar appearing pneumonia. This is a posterior anterior view of the chest. You can see the spine is superimposed on the heart. This x-ray is not rotated. This looks apparent female patient. But anyway, Covet pneumonia, there you go. This is a cavitary infiltrate or cavitary lesion. Look at the left middle lung field. You can see that there's a cavity there, and then think of it as that. There's a cavity containing something. Generally has a thick wall, sometimes contains metastases, but can have other things in there. But that is a cavity appearing infiltrate. Another cavitary infiltrate. Again, you can see that as a cavity. It appears to be cystic appearing. Generally have thick walls. If you see the large black arrow at the bottom pointing to the bottom lower wall, you can follow that wall around, see how thick it is, but it looks like a cavity that contains something. Again, generally metastatic, but can be from other sources. This may be a little advanced. You may not need to know this yet, but it's just a good slide and something to learn. Miliary tuberculosis. I've probably seen this twice in my life. I think I've been in nursing for 18 years. I've seen this twice in 1 year. So this is miliary tuberculosis. This is what it looks like. Know it so you can recognize it just in case. Left upper lobe mass. You can see this mass. You can see it differentiate from the cavitary lesion we looked at earlier, where it doesn't look like a cavity with thick walls or cystic appearing. This is just a dense mass. It looks like if you would put a golf ball there. It doesn't appear hollow. It doesn't appear fluid filled. It's a group of tissue. Cannonball lesions. I don't know if I've ever seen this in practice, but these are generally metastases as well. Cannonball appearing masses. They look like cannonballs, but these are normally metastatic lung lesions. So pneumothorax, again, when evaluating a chest x-ray, you want to look at the lung fields and make sure they have lung markings, right? And so you can tell that by looking at this image in the left lung, which is on the right side of the screen. The left lung, you can see the definitive line, the border, where if you look at the lung space, you see lung tissue, you see lung markings, the definitive line, and then you have blank air space, which is air. So you can see this probably about a 50% pneumothorax on the left side. Here's another one. Can you see it? You can't really see the border, but you can look at that right lung, which is on the left side of your screen. The right lung has no lung markings. You can see just around the area of the right atrium. It looks like a deflated balloon, which is what this is. This is a complete pneumothorax, the beginning of a tension pneumothorax, which we'll get into in a minute. This is a tension pneumothorax. Obviously, it's a pneumothorax, right side. You don't really see lung markings. You see the what remains of the deflated lung near the right atrium. But look at the top where you have some tracheal deviation. This is a tension pneumo. Again, you should be able to diagnose this before you even get an x-ray. Obviously, they're going to have absence of lung sounds in all lung fields on the right side. They'll be in some degree of distress. May or may not have hypoxia, honestly. Pneumothorax patients, even tension pneumo, don't always have hypoxia. They are ventilating enough sometimes. But generally, they've generally had some type of trauma. You can't have spontaneous pneumos, which occur in tall, thin people. Generally, they have a pop bleb, but pneumothoraxes normally have a trauma. They normally have some pain, but they definitely are missing lung sounds. Not diminished, not abnormal, but missing. You can't hear any air movement because there is no lung tissue there. So I'll tell you, this is the first x-ray I ever missed as a nurse practitioner. Not a tension pneumo, but I had a probably 17 or 18-year-old kid come in, or a young adult come in when I was working the ER. I don't know, 6'3", thin guy, came in, no fever, sat 96, saying he had a cough, and every once in a while when he breathes, he felt like he could hear a gurgling sound. It shows up a little bit of a red flag, but I listened. I really thought I heard good breath sounds. I did an x-ray. I didn't see anything. Treated the kid for bronchitis, sent him home, and radiologist called me about 20 minutes later saying this kid had about a less than 10% pneumothorax on the right side, and it was very difficult to see. I had looked at it on a regular monitor instead of the PACS monitor, which is policy for us to do. So I had to call this kid back. He didn't have an adequate phone number. Nobody knew him. His address was incorrect. I finally got him tracked down by the sheriff's department, and they brought him back in, and he just got admitted for obs. I don't even think he got a chest tube because it was small and symptoms had been going on for 3 days. But anyway, pay attention to the assessment, not just the x-rays. So it's a lung mass with a pulmonary effusion. We mixed it up a little bit. We moved on from pneumothorax. You can see the effusion in the left lower lung fields. You can see the mass just superior to that in the middle lung. This looks like it might be an AP view and not a PA, and it's a little rotated to the left. Just look for those things. But it looks like it's hard, man. This one's kind of difficult. Maybe you guys know better than I do. But anyway, you can see the pulmonary effusion. You can see the mass. You can see in that left lung they have blunting of the costophrenic angle. That sulcus is filled in, and you can't see it there. A lot of times, lung effusions are from lung masses and from cancer and metastases, so you'll see them go together. Sometimes you just see the effusion and not the mass. Sometimes the mass and not the effusion, but a lot of times they go together. And I also want to say that effusions aren't always a result of a mass. Pneumo Mediastinum, this is way advanced from what we need for this course, but you see it there. Not that common. Normally is a big deal. They've got something else going on. But Pneumo Mediastinum, a very subtle finding. More pneumothorax. You can see this one on the left side. Don't see much lung markings at all. Hard to see a border. Looks like a tension pneumo. There's some tracheal deviation. This patient is rotated as well. Obviously a trauma patient. Look at all that on the right side. It looks like there's some air in the soft tissues and other things going on. But anyway, this is a AP supine pneumothorax. All right, so there's a lot going on with this patient. See if you can find it. Maybe cut the volume off and see if you can sort of interpret this one. But this is overall looks like a young person. Right and left humeral heads look like they have some growth plates, diaphysis there, metaphysis. He's got a left midshaft displaced clavicle fracture. He's rotated towards the left. He's kind of curled up. It's a difficult position. He's got a right-sided pneumothorax, probably 25%. He's got a chest tube in place. You can see it up there around the tip of it, around the second, third rib. Right lung looks okay. He's got, I don't know, There's that's an NG tube. It doesn't look like an ET tube going down his trachea. It looks in the esophagus. I don't know. That's really a hard one for me. But anyway, this is a right-sided pneumothorax with a chest tube, a clavicle fracture, and a teenager who's rotated towards the left. So pulmonary edema, often indicative of congestive heart failure, but not always. Could be ARDS, which presents often the same way radiographically. You have to differentiate it clinically. You have to differentiate ARDS from a cardiogenic pulmonary edema versus non-cardiogenic. So this patient has it all. They look like they're in stage 4 with alveolar involvement. So there's 4 stages of pulmonary edema, and we'll go through those. Oftentimes, when we look at it, we will catch them early, and they'll be in just they're having increased vascular congestion, where you can see prominence of the vasculature of the lungs, and we'll look at that as well. But this case is pulmonary edema. You can tell because it's widespread. It infects nearly all lung spaces. Doesn't look like lobar pneumonia, but there's haziness. You can definitely see that this is an abnormal X-ray. So here's sort of the 4 stages of pulmonary edema, or severities. Number 1 is no edema. Obviously, is a normal PA of the chest on the left one. And again, I apologize because these are a little small, but it was a good side-by-side comparison. You can blow this up, and for purposes beyond for reasons beyond the purpose of this course, I can't totally cover everything about pulmonary edema, but I do want you to study the different types as far as vascular congestion, interstitial edema, and alveolar edema. Very important as far as the progression of pulmonary edema. So study those differences. Study that on your own. You will get into this a little more later. Right now, we're focused on a screening chest X-ray to determine if this patient has this abnormality, and then what we need to do from here. So no edema. You can see in the left one they have increased vascular congestion. Compare that one to the left slide, where you can see that their vessels are congested. They have extra volume in them. They're a little expanded. They're more prominent. They're more able to see. And then you get to the next slide where they have interstitial edema, where they have haziness of the lung field, not just the vessels and the vasculature, but that their interstitial aspect of their lungs are beginning to have edema. And then you get to the alveolar edema, which is the same as the previous slide, or similar to the previous slide. You just have widespread edema, congestion, haziness. This is a severity level 3. So know what you're looking for. Really, vascular congestion, you'll see that a lot. If you read a radiologist's interpretation, they'll say increased vascular congestion, suspect congestive heart failure, or something like that. But again, we're really wanting to be able to look at these X-rays, know what's normal, know what's abnormal, and at least know what that abnormal is. It looks like vascular congestion. ARDS, acute respiratory distress syndrome, wet lung, respiratory distress syndrome. How does it appear on X-ray? Oftentimes the same as pulmonary edema. It has the same appearance as congestive heart failure would. You'll have widespread opacities, infiltrates, haziness appearing. You cannot differentiate ARDS from congestive heart failure or cardiogenic pulmonary edema by chest X-ray alone. You must look at the cause. So if you have pulmonary edema on a chest X-ray, normally it's congestive heart failure. Clinically, we correlate clinically. We take a good history, a good exam. We look at the reasons why this patient may have pulmonary edema. They may have an elevated BNP to help support that, and maybe even echo, and we can say, well, this person has cardiogenic pulmonary edema. They have congestive heart failure. ARDS, there are many causes. They're all fairly rare, except the most common is probably sepsis. But there's so many. Inhaling chemicals, different types of lung injuries. So you really, when you see ARDS, know that you have something there, and then know that you really need to differentiate it from congestive heart failure. These patients aren't going to respond to Lasix, because
It's not from heart failure. It's from something else. You give somebody Lasix, you treat their CHF, their pulmonary congestion will heal up or disappear in a few days. Patients with ARDS, these X-ray findings will last for weeks, and we'll have some lifelong residual findings as well, generally. So this patient has it all: ET tube, NG tube, central line tip, even got some gown snaps on here. This is just a good overall picture of placement, what a typical X-ray is going to look like. They're not always going to be clear, not always going to be well defined, but in the next few slides we're going to go through determining landmarks and knowing how to identify the proper placement of the things we put in people. ET tube and central line placement. For endotracheal tubes, locate the carina, which is the fibrous ridge that separates the right and left main stem bronchus. That is the point there that the blue arrow is pointing to, labeled carina. Somewhere around the 5th and 7th thoracic vertebral bodies is where the carina is located. You want the distal end of the ET tube to be 4 to 5 centimeters above that. Some texts say 2 to 4 centimeters above that, but I believe the standard is 5 centimeters above the carina is an acceptable location for the distal end of an ET tube. Again, please know your standard of care and correlate that with what your accrediting body says, but 5 centimeters above the carina pretty much ensures that it's not going to be pulled up into the vocal cords or pushed down into either of the main stem bronchus, causing hypoventilation. So there's your landmarks. Safe window for line tip. On the left is the green writing. That is the superior vena cava, all the way down to the tip of the right atrium. That is where you want to see the distal aspect of a central line. So these next few slides bounce around a little bit, but follow with me. So this is an abnormal central line placement. Hopefully you can tell that by now, even just from the previous slide we went over. You can see that central line is, I really don't know where it is, but it's not in the right place. So abnormal ET tube placement, you can follow that down and look at the tip way down in the right main stem bronchus, past the main stem bronchus. And you can see again why things generally go towards the right main stem, because of its vertical displacement. But look at this X-ray. You can identify the carina on here. Go up 2.5 to 4 centimeters above that, and the tip is not there. It's way down in the right lung. More ET2 placement and central line placement. These both appear to be incorrectly placed. The yellow arrow is pointing to the central line catheter tip, which appears to be down into the right atrium. For standard of care purposes, you need to be in the right the superior vena cava. Some texts argue, and some studies show that yes, you can have it in the right atrium. Know your standard of care. Know what your accrediting body says, but the distal tip of that catheter should be in the superior vena cava, proximal to the right atrium. And then this ET tube that the orange arrow is pointing to is down, entering into the right main stem bronchus a little bit. Not all the way down into it. It's a little bit above the carina, but you can see how you're going to hypoventilate that left lung, and this patient is going to have a good outcome. So these are both incorrectly placed. It's just more anatomy on ET tube placement. Again, the carina, which is somewhere between T5 and T7 on this patient, the tip looks about to be right at the middle of T6. So you want to go about 5 centimeters above that, where you want your ET tube to be placed. Just another good visualization. An image of a correct placement of the ET tube and central line. This is a close-up. It's a little harder to see, but you can see that the central line is in the superior vena cava. The ET tube is up a few centimeters above the carina in the proper location. That's it, folks, at least for this patient.
Hope you got a lot out of this. I hope you learned whatever it is you needed to learn. Thank you for listening and paying attention. Please, if there's anything that you disagree with or something I blatantly did wrong, or if you want to praise something I did and tell me something you learned, feel free to email me, Matt, MATTFNP, @gmail.com. I'd be more than happy to hear from you, more than happy to provide any answers that you may need. Good luck in your studies, guys. Thanks.